So now we are going to start the formal program for today. Of course, you all know my name, Sriram Mulgun, and this is the program for August for the Senior Forum of the Marathi Bhatik Mandal. आपण नेहमी म्हणतो की म्हातारपण म्हणजे दुसरं बालपण असतं. लहान मुलाला आपण चालायला शिकवतो. मूल मोठं झालं की त्याला स्वतःच्या पायावर उभं राहायला सांगतो. तर तीच गोष्ट आयुष्याच्या दुसऱ्या टोकाला गेलं की पुन्हा सुरुवात होते. की गुडघे दुखायला लागतात, सर्जरी होते. मग डॉक्टर आपल्याला उभं राहायला शिकवतात, चालायला शिकवतात. आणि हे सगळं काम करणारे आपल्यापैकी एक डॉक्टर हेमंत शिराळी आज आपल्याला नी सर्जरी संबंधी आणि त्याच्या संदर्भामध्ये इतर गोष्टीमध्ये आपल्याला माहिती देणार आहेत. तर त्यांची माहिती देण्यासाठी मी शशी जोगळेकरांना विनंती करतो. शशी.
नमस्कार मंडळी. परदेशाहून कॅनडा स्थायिक होण्यासाठी बरेच द्राविडी प्राणायाम करावे लागतात. या नियमाला अनुसरून इतर देशातून कॅनडात आलेले सर्व डॉक्टर त्यांना इच्छा असलेल्या विषयात रेसिडेन्सी मिळवून त्या विषयाची स्पेशालिटी अर्थात वैशिष्ट्य संपादन करतात. कॅनडाच्या उच्च परीक्षेस बसण्यासाठी रेसिडेन्सी करणे आवश्यक असते व उत्तीर्ण होण्यासाठी अभ्यास, ज्ञान, कष्ट आणि नशीब या तिन्हींची कसोटी असते. आजचे वक्ते डॉक्टर हेमंत शिराळी यांनी सर्व दिव्यांचा सामना केलेला आहे. 1982 ला पुणे महाविद्यालयातून MBBS व नंतर तिथूनच 1985 ला MS ऑर्थोपेडिक्स झाले. त्यानंतर इंग्लंडला MCH ऑर्थ ही पदवी संपादन केली. पुढची काही वर्ष कॅनडाच्या सॅस्कॅच्युअन ह्या प्रांतात ऑर्थोपेडिक कन्सल्टंटचे काम केले. जून 1999 मध्ये ओंटारियोला स्थलांतर केले. ओंटारियोचे स्पेशालिटी मेडिकल लायसन्स मिळवण्यासाठी 1999 ते 2001 पर्यंत मॅकमास्टर युनिव्हर्सिटी हॅमिल्टन येथे ऑर्थोपेडिक रेसिडेन्सी केली आणि आता 2001 ला FRCP कॅनडा अभ्यासक्रमाचे हे शेवटचे ध्येय गाठून ते आता निश्चिंत मनाने स्टॉफिल हॉस्पिटल मार्खाम येथे प्रॅक्टिस करतात. हॉस्पिटलचे काम उदरनिर्वाहासाठी करीत असताना त्यांनी आपला जॉगिंग आणि माउंटन क्लाइम्बिंगचा छंद सुद्धा जोपासलेला आहे. थोडक्यात सांगायचे म्हणजे जीवनात शक्य असेल तेवढे उंच शिखर गाठण्याचा त्यांचा हव्यास खरोखर वाखाणण्यासारखा आहे. अशा जाणत्या व्यक्तीकडून आज मिळणाऱ्या माहितीचा आपल्याला नक्कीच लाभ होईल हे निर्विवाद. आता मी कार्यक्रमांचे स्तोत्र श्री मुळगुण यांकडे पुन्हा सोपवतो.
Okay, Hemant, the forum is yours. You can.
Okay. Namaskar. It's a great pleasure to be here with all of you today. Very appreciative of Dr. Ashok Wardekar to ask me a couple of months ago whether I'd be happy to share some basic information about knee arthritis, which is my specialty, with you all. And Shashikaka, thank you for the kind introduction. I see many familiar faces here, and I'm wishing them as well. So today I'm going to speak on a subject that is extremely common in our community, which basically deals with the mobility of locomotion in human beings. The topic is basically stand on your feet and keep moving. And we all take mobility for granted. in our daily lives. We don't think about it, like hearing, vision, sense of smell, other senses. And until things are going well, we don't really think that the problem will happen to you. But as you know, it's a very common problem. And at some point in life, there will be a significant number of people who will start experiencing this difficulty. And that is when that's when we need to really know what options we have when you get pain in the knees. So this slide I put out because it takes me back to memories of childhood. And I was very attached to my grandmother when I was young. I was the oldest of the grandchildren, and she totally spoiled me. Back when I was almost right from 5 to the age of 10 and 15, she used to be very active. And I used to go to the temple with her, walking at least 2 to 3 to 5 kilometers very often, 3-4 times a week. That was a chore that was a task that we did very regularly. As time went and I became older, I realized that this active person slowly started losing that mobility. And by the time I was in medical school, around the age of 18 years, she had reached a point where she was literally immobile. She had developed severe deformities of her knees. She had difficulty in getting up and walking. And in those days, I used to wonder, I said, Ajit, there must be some treatment. I'm sure there must be some treatment that you can do to get rid of this pain. Little did I know that at that point, there was really very little. Surgeries had not started for total knee arthritis. And most of the patients just accepted their fate and led a life which was quite sedentary. So now you have to remember that aging is not a lost youth, but with all the technological advances and improvements, it's a new stage of opportunity and strength for people with arthritis. So osteoarthritis of the knee is fairly common. It affects about 16% of the population and generally affects people after the age of 40 to 45 years. And women are more affected than men. There are several risk factors which predispose to people getting arthritis. Age is, of course, number one, because it's basically a process of wear and tear of your tissues, of your cartilage in the joint. So age, as you grow older, some people they lose their cartilage early, and age is a big risk factor for those people. There's also a hereditary component where patients who have family history of arthritis there'll be a significant chance that they will develop it as well. Similarly, there are certain occupations, construction workers, people who are working in Home Depot, Costco, walking and standing for lengthy hours of time and walking on concrete surfaces. So those physical tasks, they predispose patients with get arthritis. Injury, obesity is another huge factor, although that's not necessarily always true. But there are pre-existing deformities, such as you may have seen people with curved knees or bow legs, where arthritis develops faster, and other people who have knock knees, who also get people who are kind of neutral and the alignment is normal. There's a lesser chance of them getting arthritis. Let's talk about what the symptoms of arthritis are. And the commonest symptoms or the common main symptom is gudghe duktat maje. Basically just pain. The pain can be a dull aching pain, it could be a sharp pain, it could be on a scale of 1 to 10, it could be mild discomfort, 2 out of 10, but as the arthritis increases, it can be more in severity, go up to 8 out of 10, and sometimes it is constant, sometimes it comes and goes. So there's a huge spectrum where pain can be from one end of the spectrum to severe pain on the other side. Pain is also associated with stiffness, where range of motion in the knee gets affected. Those people who are able to bend their knees fully, they find that I can't bend like that before. It's not uncommon to find that with changes in the weather, the pain and the discomfort also increases. So some of these patients can actually predict whether it is going to rain or cloudy. Sometimes they can relate to that. Because arthritis causes some swelling, there's usually some warmth or swelling. And another feature of arthritis is crepitus. Crepitus in Marathi, I can say crepitus manje, when you're bending the knee or moving it, you can hear crackling, cut, 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 asa awaz yeto. When you're squatting or going upstairs, you're just moving the knee. Along with these, there's a very slow, gradual progression to, it may start mild, but as the disease progresses, it becomes more severe, the pain gets worse and the deformity gets worse. And essentially what happens is their mobility changes and the function deteriorates. So for example, if a person can walk up to 5 kilometers or about an hour every day, very active person, over a period of time, the ability to walk that distance gets decreased and limited. Then they start getting pain for short distances, even going to pick up your mail from the mailbox. Getting up and down stairs is difficult, and walking distance reduces. And as the arthritis gets worse, they feel that, oh, it is easier with a cane. And in the most severe cases, some of them may require a walker. Another point that I forgot to put on this slide is called startup pain. Startup pain is a fairly early sign of arthritis. So startup pain means when you're sitting in a chair for a long period of time or sitting on a commode, when you get up like this, just that attempt to get up from a sitting position, the patient say, oh, that hurts, doctor. It is called startup pain. Once they are up, the pain is not so bad, but the whole process of getting up from a sitting position is affected. So I put some slides here because I could, in theory, show you several slides of the description of arthritis, but nothing like actually seeing the inside of a joint. So the picture on the left, this one, is a normal joint. What you see there is the kneecap or the patella here. Vati म्हणतो आपण, गुडघ्याची वाटी. That is here. And this cartilage, this white area here, which is smooth and glistening, that's the cartilage. So in this normal knee, you can see that the cartilage is pristine, it is clean, it looks like new. As wear and tear happens, this is early arthritis. You can see small patches. There's a loss of cartilage, small little patch here, here, here. So at this stage, and you can see a little bit of spurs here, chote chote. This type, I don't know whether people can see, but
Yeah, we can see. I can see that.
Yeah. So this is mild arthritis. People with mild arthritis can carry on for a long time without needing any treatment. So it's not that mild arthritis meant like you need to intervene, nothing like that. But I just wanted to get you a visual of what this looks like. So in moderate arthritis, this is on a scale of 10, it's about 5. You can see there is more loss of cartilage. This white area is called articular cartilage. Essentially, this is what is arthritis. So basically, there is cartilage loss on the femur. This is the end of the thigh bone. There's cartilage loss on the tibia. You can see there are craters, there are potholes, there's complete loss of cartilage, and you can see these spurs. So at this point, the symptoms certainly become worse, and these patients find it difficult to get moving. Here's an example of severe arthritis in the knee, where there is severe loss in all the 3 compartments. It's irregular. I mean, it looks horrible. I mean, even to a layperson, you can see and understand that This is an extreme case where there is no cushion between the ends of the bones. There's very little normal cartilage left, and the rest is all damaged. So this is what we're going to be talking about, how to treat this condition. Another example is on a pathological specimen. This is a cut section of a healthy joint. You can see a good thick layer. This layer is about 6 or 7 millimeters. And the brown substance, brown color you see here is the bone. So this cartilage is on the bone. So over a period of time, this starts getting bald. You start losing it, all that loss, all that, that cartilage pieces, the loose bodies, everything that gets, all this becomes, when it becomes severe, this is what it looks like. This is like a smooth surface, and this is like the surface of a moon with craters and erosions. Here's an example of a normal joint where the person is happy. There's no need for any treatment. This is completely normal. Normal cartilage here, normal cartilage here. This is the synovial fluid, or it's the fluid that lubricates the joint, this color here. And these are the bones. And when it gets severe, this is the picture of a patient in pain because there is no cushion. All the this is advanced end-stage arthritis, and this needs treatment. So these are slides of the inside of the knee, which I've taken while doing arthroscopic surgery. Arthroscopic surgery, it is basically a fiber optic laparoscopy. You must have heard of laparoscopic surgery, endoscopy. So basically we put a telescope, which is as thin as a 4 millimeter, like a pen, inside the knee. And the whole joint can be seen with this camera, small camera at the end of this lens. And it is like you're sitting inside the knee. You're sitting inside the knee and you can see everything. So this is how normal cartilage looks. Actually, that was all pictures from other places. This is actually what it looks like. So you can see this is normal cartilage. This is a meniscus, which is a shock absorber, which is cartilage again, and this cartilage. So it looks normal. This is what a patient with moderate arthritis will look like. This is, you can see this meniscus, this is torn here. You can see this cartilage getting irregular and so on. Earlier in the talk, I had mentioned that pre-existing deformities can be a precursor for arthritis. So this is an example of somebody with bow legs. These legs are bowed. Sometimes they can start with mild, with a normal alignment, and then it becomes gradually severe. So here's an example of bow legs in this patient. This patient either has arthritis or has had a bow leg from past, and the arthritis become worse. The picture on the right is an example of knock knees. So both these kind of patients with these alignments, and these are how you're born with. This alignment is hereditary, it's genetic. There's no control. This is the shape of the body that we will have. I hope this video works. This is an example of a patient who...
Slowly.
Yeah, slowly. You see how slowly he's walking. He's having difficulty taking a step, and he's got severe bow legs. Were you able to see that video?
Yeah, it was quite clear.
Okay. So just wanted to show this to show you an example of how a severely arthritic patient will walk. So when you start getting symptoms, then the symptoms get kind of bad enough. Then you start getting worried that, oh, now I realize that I'm having trouble walking, I'm getting this startup pain, getting up, because of pain. You take Tylenol, you take other medications, and I say, okay, now it is time to visit the doctor. So what is your family doctor going to do? So the first step for you is to consult your family doctor. And the family doctor is going to ask you all the questions that were there in the first slide to find out whether your condition is mild, or is it moderate, or is it severe. So that involves a process called history taking and a physical examination to find out how severe your disease is. And after that is done, he will get an idea that, okay, maybe this patient has mild arthritis, doesn't need any treatment right now, but we should maybe get some x-rays done. So in this day and age, I get a lot of referrals where patients go to the doctors, and along with a referral letter, there is an MRI attached to it. Unfortunately, because all these fancy tests are available, MRIs are done by some doctors and sent to me, but that should not be done. The first basic thing that one needs to find out how severe or mild your disease is proper x-rays. And those x-rays have to be done in the standing position. The reason I'm saying this, because some of you may be potential patients, and if the family doctor orders x-rays and they're taken in the lying down position, maybe you should just tell the technologist or the family doctor that ubha raun x-ray kaadhaयचे मला in the standing position. Otherwise, all your x-rays will have to be repeated when you come and see me. And the reason for that is what we are interested in seeing on the x-rays is the gap between the two bones. When you're lying down, the gap may look normal even, but when you're standing up with all your weight on the body and on the legs, you will see the true gap. So just a small point, this should be actually directed to the family doctors, but since some of you may be having some x-rays in the future, just remember that the only thing that Dr. Shirali had told me on that talk was standing x-rays. Ubhe raun x-ray kaadhaयचे. That is important. Ultrasound scan is of no value in arthritis. So if an ultrasound is ordered, I would not even look at the result. MRI scans are only needed in certain conditions, which I'll come to later. So this is how x-rays should be taken. So you can see in the standing position, this patient is standing here. You can see with the naked eye as well, ki kiti vakde आहेत त्यांचे पाय. So these are called bow legs or genu varum, and this man has severe arthritis in the left knee. So here's some x-ray examples that I would like to just show since we are on this important topic. Let's go to the first x-ray in the middle, where my cursor is. What you're looking at is a normal x-ray. And why is it normal? Because in this standing view, this gap here and this gap here, normally there should be a gap, and this gap is equal and it is symmetric on both the inside of the knee and the outside of the knee. However, on this picture on its left, you can see, I hope you can appreciate that the gap here is normal, but here there is no gap. What you see is complete obliteration of the gap and wear and tear, and this is severe arthritis. Again, here it's a similar picture where you can see that there's no gap. It is bone on bone. This is what we call bone on bone. And when patients reach this stage of arthritis, they can barely walk. And when they come to us in this stage, the treatment becomes more complicated from the surgical point of view. The recovery gets more longer, the complications are more. So it is, unfortunately, because of the trends in our culture and fear of this surgical treatment for the arthritis, a lot of patients in our community and others as well come to us with this end stage disease, which is not easy to treat, but with good technology and surgical techniques, we are able to get a good result. But it's still a huge challenge for both the surgeon and the patients. I just put up this picture to show you MRI, what an MRI looks like. I'm not going to go into the details of MRI in arthritis. I just wanted to know, this is what x-rays look like, and this is what MRI looks like. Usually for knee arthritis, we usually do not need an MRI. unless the arthritis is mild. So let's go to the treatment options. So once we have decided that a person has arthritis, our job is to classify whether this is mild or is it moderate or is it severe. So in mild arthritis, what mild arthritis patients would typically have is, I do get knee pain, but it is manageable. I used to walk 5K, but I can still walk about 2 to 3K. I don't have pain at night. I can go up and down stairs. If I stand for too long, it hurts. I get stiffness. So overall, everything is manageable, but I'm a little concerned because my knees do hurt and I need some treatment for that. So simple treatment options. So these kind of patients do not need an operation. So the hallmark of treatment is non-operative, which involves weight reduction in patients who have a high BMI or body mass index or are obese and overweight. Weight reduction becomes a very important part of treatment. And some patients are very sensitive to being told that they need to reduce weight, but it is important that the message goes across. Very simple treatments like exercises are important part of treatment. And a lot of times I see patients or come across friends and family who say that I'd gone to the doctor and he took x-rays and everything and he did nothing to me. I said, what do you mean he did nothing to you? What did he? He said, no, just do some knee exercises and that's all you need to do. So I said, I have to emphasize that knee exercises are very important. Just moving the knee like this few times a day is not exercises. Exercises you can learn from either a good physiotherapist or you can go on Google or YouTube also. There's some very good information on exercises. These exercises, the goal is to strengthen the quadriceps muscles. So the quadriceps muscles are the main muscles in the knee, the thigh muscles. And what happens is when a person gets arthritis, there is pain. And when there's pain, one usually doesn't want to use the joint or move it. So the secondary effect is if you don't use a joint, the muscles get wasted. And because they get wasted, it is more difficult to function because the strength is not there. So it's a vicious circle where you get pains, so you don't move. If you don't move, the muscle gets inhibited or wasted. And when that happens, the knee becomes weaker. It's also painful, more weakness, more trouble, a whole vicious circle. So if you don't exercise, you're certain to lose function of that knee and mobility is going to be severely affected. So exercises are important. I don't have enough time to talk to you about the specific exercises, but you can go to physiotherapy, that's a part of treatment, and learn there. Medications like Tylenol, arthritis, anti-inflammatory medications, naproxen, Celebrex. So there are many medications available. Topical gels and creams are available, and activity modification. So there's somebody who is doing a certain activities which is aggravating their pain. You have to tell them maybe, change your activity you're doing or alter the situation at work and so on. So here are just a few examples. I went to the slide which was here before. Celebrex is anti-inflammatory medication which is commonly used in arthritis. You can use knee braces. There are different types of knee braces. There are hot and cold packs, physiotherapy and exercises, and Synvisc. I don't know how many in the audience have heard of Synvisc or gels, but this is an important part of treatment. So let's go back to injections. Before injections, let me just go back to moderate and severe arthritis. So those are the treatments that you need for mild arthritis. In mild arthritis, nobody needs surgery, nobody needs injections. It's just exercises and weight reduction and physiotherapy or some anti-inflammatory sometimes. When the arthritis gets a little more, then you have to do more physiotherapy, more exercises, weight reduction, and injections. So this is where some injections can be used. So cortisone is a very useful injection, and it is very commonly used by rheumatologists for treatment of knee of arthritis. I use cortisone injections or suggest that a patient has cortisone injections only for flare-ups. And the reason for that is a cortisone injection will 100% give the patient excellent relief for a very short and unpredictable period of time, which could be either maybe 2 weeks to maybe 2 months at the most. But when you give the cortisone injection, cortisone is actually bad for the health of the cartilage. And typically what happens is if the patient does not want surgery, he will keep going back to the doctor and say, can you give me that injection you gave me like 3 months ago? It had given me good relief. So please do it again and again and again. And what happens is the cartilage is going to get damaged and the arthritis is going to escalate at an even faster rate. So the only time that I will suggest anyone take cortisone is for an acute flare-up where that patient has arthritis but has got a sudden flare-up because of some activity he or she has done, or a patient knows that he needs a knee replacement but is not able to have it because of work-related issues or personal health reasons or some other reason. But if that person comes and says to me, and this is quite common, that doctor, I know I need an operation and I cannot have it now, but I need you to help me because, you know, my daughter is getting married in next month or in 2 months, and I'm getting a lot of visitors, and I need to have complete relief for those 10 days or 2 weeks. And I know this is not going to cure my arthritis, but if you can give it to me, I'll be most grateful because for those 2 weeks, I will have wonderful relief. So that is a reasonable thing. As long as the patient knows that I'm not going to keep giving it again and again, once in a while, that is okay. Cortisone injections generally should be avoided in diabetic patients because it increases the risk of infection, and also it affects sugar levels after the injection. They go up and down. They're very volatile after this injection for a few days. The second injection that is used for arthritis are the gel injections. So Synvisc is just one of the brands which is available, and it is based on the fact that every knee joint or synovial joint in the body has fluid. That fluid is called synovial fluid. That fluid is a lubricant in the knee or the hip joint or the ankle joint. And because that fluid is there, the joints can move quite freely. So in arthritis, the amount of fluid is altered and the lubrication function gets disturbed. So one of the treatments is to inject the synovial fluid, and there's a substance called hyaluronic acid, which is a gel, which is a lubricant. So this is available in pharmacies as a gel, and that is injected into the knee. So this is not covered by OHIP. Cortisone injections are usually covered by OHIP. They're cheap. This costs about $500. And if you've got a good drug plan, then it'll probably be covered. So this could be considered. It is very safe because it is a normal constituent of the knee. It is just replenishing that. So all it requires is one injection, and it doesn't cure the arthritis. And you have to tell the patient that it may or may not give you relief. The success rate for this treatment is about 50 to 60% only. But if you are in the lucky 50%, patients can expect relief for 6 months to a year. So I just wanted to know that there's these options of the gels. So if you go to the doctor, you can ask them, okay, I'd heard in a talk that there's some gel injections available. Do I qualify for that? Should I take it? And that's a discussion which you can have with your family doctor, or you can have with the treating orthopedic surgeon. So it's quite a useful drug. There are newer treatments that are being utilized for knee arthritis. One of them is plasma-rich protein or platelet-rich protein therapy. So what is done in this is 20 cc's of blood is taken in a doctor's office. Just like when you go to the lab, they do a routine blood test. This blood is taken and it is centrifuged in this machine here. And the total amount of blood is 20 cc's. This tube is put into this centrifuge machine, and after 10 minutes, it is separated. So what is separated is this yellow line is the plasma, which is a portion of your blood is plasma, and the rest of it are blood cells. So this is the red blood cell portion. This is discarded. This is thrown away. And this plasma, which is about 7 to 8 cc's out of this 20, is injected into your knee. So it is your own tissue, blood tissue component, which is being injected into the knee. And the rationale behind doing this is the plasma contains platelets, which are rich in many factors which control and decrease inflammation of the knee. Because of the fact that arthritis causes inflammation, and that inflammation causes pain and swelling and stiffness, by doing this, all that rich plasma, all those factors help to relieve the pain and the swelling and the inflammation and improve function. So it is again not covered by OHIP. It is approved by Health Canada, and it is safe. There are small risks like infection or bleeding, but overall it's a very safe procedure. One has to very clearly tell the patient that this is not a substitute for surgery. Otherwise, a lot of patients come with the expectation that I'm going to spend $650 out of my pocket to get this. Some offices may charge you up to $1,000 as well. And they expect that their life will change, or the pain will go away, or the disease will get cured. A lot of my time is spent in telling the patient to have very realistic expectations that this is a procedure which is going to be useful, maybe to just delay the need for arthritis. So, otherwise the patients get very disappointed, where everybody is used to free coverage because of OHIP, and here you have to pay for a procedure out of pocket, and it doesn't give you the desired results. So the efficacy of this is about 70%, which is, so if cortisone is here, gel is here, PRP is here. So it is slightly superior to the Synvisc or the gel treatment. So I just wanted to know that these are the options. If a patient comes to me, I tell them that you really need a knee replacement because that's the only procedure that will give you predictable relief of pain and improve your function. If you don't want to have it, if you're not ready for it, if you have fears about it, then you can try these things, but these are not guaranteed to give you, adequate relief, but you could try them. So I just wanted to let you know that this is available. Patients come and read a lot on the internet and come and tell me, Dr. Google told me that there is another treatment for this. It's called stem cell therapy. I've got a lot of money, doctor, and I'm happy to spend even $10,000, $20,000. Can you do this for me? The answer to this question is stem cell therapy is still under experimental use right now. It is not approved by Health Canada. So in Canada, we are not doing that stem cell therapy. In the US, there are centers which are doing it. But again, there is no long-term or complete data to show that it really works. So I'm not going to talk about stem cell therapy because I don't do it. So finally, once you've tried everything that I mentioned before, and the patient comes to me and tells me that, oh, doctor, I've been coming to you for the last 5 years now. Remember, I came when it was mild. I did exercises, I lost weight, I took all these medications, and I've soldiered on, but now a point has come where I cannot bear it anymore. So when a patient comes and tells me that he's taking 3-4 Tylenols a day, or taking anti-inflammatories or narcotic medications, cannot sleep, cannot climb stairs, needs a cane, uses a walker, a time has come when this patient needs surgery. So what kind of surgery can be offered for these patients? There is a surgery called arthroscopic surgery, which I'm just mentioning in passing because it is really for mild disease, and it is only for patients who have mild arthritis, but mostly the pathology is meniscal tears. I didn't go into the details for that, but that has a place in treatment of arthritis, but the surgery is not done for arthritis. It is done for people with pain in the knees from tears of the cushion inside the knee, which is the meniscal tear. And if that patient has just mild arthritis, then that is a useful surgery. Arthroscopic surgery is less invasive, just takes about 15 minutes. It does need an anesthetic, and it is ideal for patients with less arthritis and for symptomatic meniscal tears. So this is an example of arthroscopic surgery where you can see that his cartilage looks beautiful. This is normal cartilage, white, smooth cartilage, but his main problem is this meniscus tear. You can see that this is the meniscus, this is the cushion. In real life, it feels like your earlobe. It is cartilage, it's a shock absorber. So it does get torn sometimes, and you get these tears. So this patient does not need a knee replacement because his cartilage is healthy looking, but he's got a meniscal tear, so he has had arthroscopic surgery. This takes literally about 7 to 10 minutes to do, where we go with a very beautiful instrument called as a shaver, and it shaves off and smoothen the meniscus. Small little cuts on the knee, 1 to here, and that's it, and the recovery is quite fast. So I just wanted to show you what arthroscopic surgery. The recovery is about a week or 2 weeks. So coming back to the treatment of arthritis, there are different types of surgeries. There's a partial knee replacement or a total knee replacement. This is really the last option for severe disease. This is, however, a major operation with excellent results. The advantage of this procedure is that you can get predictable relief of your pain and return to activity and improved function with long-term benefits. So all the other things that I mentioned before, the relief is unpredictable and the benefits are very short-term. So, but this surgery takes longer, and length of stay is usually 1 day. But of course, it's more risky because it is a bigger surgery. It is a painful process. There's extensive physiotherapy that is required. In the audience, I see a few people who probably have had knee surgeries, and they can vouch that it does take a lot of commitment from the patients and do the physiotherapy to get a good outcome. It is ideal for severely arthritic patients, and the approximate recovery time is about 3 months, but it really takes 1 full year to get the maximum benefit of this operation. Oh, I just wanted to show you some other pictures of arthroscopic surgery. These are meniscal tears. There's arthritis here. So here's what arthritic looks like, a knee looks like, and this is severe here. So a partial knee replacement is a good option for patients whose arthritis is only isolated to one compartment of the knee. So for this patient, for example, who has bone on bone here, and if his pain is only on the inside and not under the patella, then uh, some patients do qualify. I'm not going to go into the details of who qualifies for what, but I just wanted to know that this is a less invasive option. It is unicompartmental, just changes one compartment, and results are excellent in well-selected patients with a very quick recovery. The hallmark of treatment, however, is a total knee replacement for elderly patients with arthritis. This is an example of what it looks like. You can see that the joint is quite damaged. There's loss of cartilage here, everywhere. It's been replaced by this component. I get asked what goes inside the knee. So this is a titanium base plate. This here is in the tibia. This is titanium. It is cemented, but you can also get uncemented components in younger patients. In the middle, this one is a liner. So we replace the femur. This is cemented. There's a liner and there's a tibia. So it takes about 45 minutes to an hour to do the surgery, and this is what the incision looks like. So this is a total knee replacement. One of the main or the important aspects of a knee replacement are, it is a major operation, so the patients have a lot of questions, understandably. We give a brochure which is printed to help the patients read it and prepare the patients for this important surgery. So, but we usually tell them that it takes about an hour to do. It can be done under general anesthetic, but usually a spinal anesthesia is recommended because it is less, because of a lot of advantages, spinal over general. Blood loss is minimum. Less out of 100 patients, less than one patient out of 100 need a blood transfusion. So that has improved a lot over the last many years. Pain is an important deterrent for patients, and many patients don't want to have the surgery because they are scared of dealing with the pain after the surgery, and that's quite understandable reason. So, however, anesthesia, techniques in anesthesia and pain management have really improved and changed the way post-operative pain is managed. So patients get these blocks. Apart from the anesthetic, which is an injection in the back, there are nerve blocks which are given above the knee by anesthesia using ultrasound. And with these blocks, the first 2 days are usually pain-free. And this is to allow the patients to get up soon after the surgery and be comfortable. And pain management is quite effective now. It has improved a lot over the last 5 to 10 years. So because the pain service or pain management has improved, patients are usually walking the same day or the next morning with physiotherapy and then home. The physiotherapy is usually 3 months, and it's usually covered by OHIP. And general recovery time is about 3 months. Return to work is 6 weeks or 3 months. And the success rate of this operation is 90%. So like with any major surgery, there are always risks involved. And I always have a discussion with the patient to explain to them that this is a safe operation, consider a safe operation. It's got excellent results, but you must remember that there are no guarantees and there are potential risks. So what are the risks? Patients who are elderly do have many comorbidities: hypertension, diabetes, coronary artery disease, renal disease, asthma. So these are our risks, but before the surgery, we do make sure that a thorough assessment of your general condition is made in the surgical assessment clinic a month before the surgery to ensure that you're in an optimum condition to have this surgery. I have to mention that a lot of times patients are completely unaware that they have a serious illness until they sign up for the surgery. So typically, I've had many patients who sign up for the surgery and say, okay, I'm ready for the surgery. I'm very healthy, doctor, no problem. And when they go for SAC, they get tested so extensively that when they are seen by medicine or anesthesia and when the tests are done, some of the patients are found to have serious underlying cardiac issues. And if that's the case, then we tell the patients to get that fixed first before coming into surgery, so that they do not end up with a heart attack or some coronary event during the surgery or after the surgery. So them choosing the surgery actually becomes a blessing in disguise for many of these patients who are completely unaware that there's something bad happening in the heart at the same time. So the risks, medical risks and anesthetic risks are clots, or DVT as we call them, heart attack, stroke, embolism, confusion. These are common. These are not very common unless you have severe comorbidities. So if the patient's doctor or the patient's internist will tell me that I don't think it is safe for this patient to have surgery, then of course we will not proceed with the operation. Surgical risks are also there. 100% surgeries are never successful. In my hands too, the success rate is about 85 to 90%. And that happens because of several reasons. One of them is that the patient could get an infection. The risk of infection at our institution is less than 1%. Bleeding is less than 1%. There could be nerve injuries or vascular injuries. Even if the surgery goes well, if the patient doesn't do physiotherapy, they end up with stiffness in the knee, or if you fall down after the surgery, you could have fractures, persistent swelling, pain. There's a whole long list of them. But the important thing is that the pain is maximum in the first week and then gradually settles over 3 months. That is important to understand. And it really takes 1 full year to get the maximum benefit from this operation. So since we are in the pandemic, I thought I would put this slide up because traditionally our total joint replacement patients would go home. 20 years back when I started practice, patients who had this surgery would stay in the hospital for about 4 days. Then it came down to 3 days. And 10 years back, it would be 2 days. And then it was about a day for the last many years, 5 to 7 years. But now, because of the pandemic worldwide, there have been severe bed shortages. So we had to switch to doing day surgeries. And that is currently what we are doing right now. Now, this is not being done for all the patients because all patients are not suitable for day surgery. Proper patient selection is important. So we only pick the patients who are in good health, who have adequate and reliable home support, who are not too old. So the cutoff may be about 75, and who are geographically not too far away from the hospital. But our day surgery patients, we are doing about 40% of them are day surgeries. Because of anesthesia, pain service, nerve blocks, patients are getting up very quick and they're getting confidence as well. Patients who've had their one knee done, when they come for the second knee, they're really confident and they say, okay, this time I'm going home same day, doctor. They only tell me that. And in spite of doing these patients as day surgery, we have found no increase in readmissions in the emergency after the surgery. So it's important to emphasize that physiotherapy and exercises is a very important part of the treatment after the surgery. I get asked this question by many patients, particularly from our community and from the Muslim community. Doctor, can I sit cross-legged? Mandikhalun bastail kamala. Namaz pad sakta hu kya main when I go to the mosque? So I just put up this slide to show you that this is a 75 or 78-year-old Sikh lady who is from the local Gurudwara here, and she couldn't sit like this for 10 years before the surgery, but she wanted to make sure that she was able to do this after the surgery. So they conveniently forget that for 10, 15 years before, they're so disabled that they cannot do it. But the surgeon should somehow make sure that I'm able to sit like this after the surgery. So the expectations from some patients are interesting. And I tell them that, listen, I'll do my best to make sure that the surgery is technically goes well. But you have to be committed and you have to put in all the effort to make sure that you exercise through your pain and make this work. So here's a perfect example of this patient who was so committed, and she said, "Doctor, मैं आपको करके दिखाऊंगी." And 6 months after the surgery, she came and she said, "Now you can take my picture to show that I can do it." Now, this is not always the outcome for everyone. So the expectations should not be that everyone who has a surgery will end up like this, but many of the patients are able to do this. Just putting a video of a patient. Hi, Fred, you can start walking. Hi, come on in. Yeah, you can walk. When did you have your surgery, Fred?
Yesterday at 10 o'clock.
Okay, and it's 24 hours now?
Yes.
How are you feeling?
Excellent.
Do you have much pain?
No pain at all.
And you can walk even without that walker?
Yes.
Let's see you do that. Wow. Okay, great. That's good. That's good. You can go back to the walker. So that was just an example of a patient to show expected recovery in an average patient like that. Here's a patient testimony of how she felt about a year after her surgery. Hello, Fatma.
Hi.
Hi. So how long has it been since your surgery now?
It's a year now.
And are you happy with the results?
Absolutely, I'm very happy.
So we did both your knees at the same time?
Yes.
And how painful was it?
It was painful the first 3 weeks, but then as soon as I started doing the physiotherapy, it helped me a lot.
Okay, can I see you walk? Okay, and you can come and take a seat here. I just want to see how much your knees bend. So if you lay flat on your back and lift your left leg up and bend your knee all the way as far as you can go, and straighten it out, and the right knee up and bend it as much as you can all the way. That's good. Okay, are you happy with this?
Yes, absolutely.
Okay, are you able to pray?
Not on the floor.
Not yet.
But once in a while I do it, and slowly I can get up and do it.
Do it.
Yeah,
Okay.
but very slowly.
Okay.
But I still pray on the chair.
Okay. Thank you.
Thank you.
So that was the treatment of arthritis, and I thought I would put up a slide to give some hints about because we get this question asked quite often. Doctor, can I do anything to prevent me from getting a knee replacement in the future, or how can we prevent knee arthritis? So my answer to them is that, listen, arthritis, one of the important factors in the pathology is genetic, or it's hereditary. So you really have no control over that. And if your grandfather or father or grandmother or mother, it's in the genes where you are born with a set of bow legs or knock knees, or if there's malalignment, then there's nothing you can really do to change that. So you have to work with what you've got. So that cannot be altered. But what you can do is, if you're overweight, then you can seriously take measures to reduce your weight, decrease your BMI. And that is something which has definitely known to reduce the rate of progression of the arthritis. It may not prevent it completely, but that is very important. Other factors are lifestyle and activity. So being active is important, but one should generally avoid any high impact repetitive exercises. So long distance runners, nobody in this group does that, I'm sure, but that is something which needs to be looked at. And exercises to maintain range of motion and improve quadriceps muscle strength. This is the key, actually. So as long as you're exercising and being active, it is important. So a lot of people, you know, to give an example, that switch from a two-story house to a bungalow because they don't want to ever do stairs, which is fine. That's a practical solution to avoid doing stairs. But I've seen people who are elderly who go up and down stairs even at the age of 80, 85, and are able to maintain that strength and function. That is commendable. So try not to avoid those, rather than you have to try and exercise and try to get up from the floor, standing position. Keep the strength in your legs. That is important. Plus other activities such as yoga, swimming, having a stationary bike in your house is a worthwhile investment. Walking, you can walk as much as you want. Knees are meant to be used for walking, so try and remain active. And other factors like calcium and vitamin D replacements, along with other vitamins, that will help. And this is my last slide. Unfortunately, this patient is going to need about 1,000 knee replacements to get better. Thank you for your attention.
Okay,
Very nice.
very nice. Hemant, you were wonderful.
Thank you.
It was a completely captivating presentation. Every word, people must have heard it. Now what we are going to do, that we are going to open up for questions and answers. So you all have been muted. So what you have to do that if you have a question, you unmute yourself, ask the question. And once your question has been answered, please unmute yourself so that there is no noise level, so we can leave it to the minimum. One person asked me to ask a question. प्रश्न असा होता की सर्जरी होते ते नी पार्ट्स जे म्हणजे गुडघ्यामध्ये टाकले जातात. What is the general lifetime for those for the knee replacement? आणि दुसरा एक सप्लिमेंटरी प्रश्न असा होता की एकदा नी रिप्लेसमेंट झाली की त्याच्यानंतर तुम्ही त्याच्यावर किती चालता किती तुम्ही एक्सरसाइज करता, does it impact the life of the knee replacement? So these are the two questions, and then we'll open for the general questions.
So the answer to your first question is when it comes to implants, you're asking me how long will this joint last? So I have to go by the evidence and the data that is available for that implant, that is available in all the published journals. So when I explain to the patient, or when the patient asks me, what I would say to the patient is that the general survivorship, how long is this implant expected to survive in your body? The expected survivorship of this implant is approximately about 92% at 20 years. So at 20, what that means is after 20 years, 92% of patients who have had this implant are still going to be walking on that implant. So there's a failure rate of about 8% over 20 years. So what is unpredictable is that specific patient, whether he or she is in the 92% or in that other 8%, that is unpredictable. But overall, there's a 92% chance that that patient will not need a second surgery for 20 years. So in simple terms, the patients are generally told that approximately this should last about 20 years. That's the first question. I hope I answered that
Yeah,
to
yeah.
your
Okay.
satisfaction.
Yeah, that's
Okay.
correct.
And the second question was, that's a very good question. That's a very good question. Was by walking more or physically stressing the implant, is it going to decrease the longevity?
Yeah, correct. Yeah.
So the answer to that is, you have to remember that when we do these implants, there are different types of patients. Here I've got a very different cohort or different kind of population. Most of us are, above 65, 70, where your life is not as active as it was 20 years ago or 30 years ago. So the demands on the implants that are going to be put at somebody at your age is going to be very different from somebody who is 50 years old, who is obese, who is active, and needs a knee replacement. So in an older population, I encourage people, once they have their knee surgery, to use it as much as they want. These implants are designed for being used for walking, for hiking, for cycling, for carrying loads. You can use them, and for day-to-day activities, there is absolutely there's no restriction to what you can do once you use once these implants have been put in. So the answer to the question is, normal activities or exercises that can be tolerated should be done, and it will not have any effect on longevity because these implants are designed to be used. But when I talk to a group who is in their 40s or 50s or early 60s, who are maybe overweight or who are very active, and their knees have become ruined or arthritic because of repetitive, heavy physical use, then I have to tell them, listen, you can do all activities of daily living with these implants that I'm giving you, but if you want to go back to that active lifestyle, your knee is not going to last more than 10 years maybe. If you want your knee to last long, then at your age, you need to look after it. So the answer to the question is, yes, if it is abused, and in a younger person who is overweight or wants to do things which are not reasonable, then the knees can get loose, they can get worn out, and they will need to be replaced again.
Okay, thank you. Okay, the floor is open. So anybody who has a question, you can.
मी कॉमेंट करू इच्छितो पण क्वेश्चन नाहीये मला.
Okay, go ahead, Ajit.
नमस्कार हेमंत.
Namaskar.
आय एम युअर पेशंट.
Oh, wait, I can't see you.
मी अजित कुकडे.
No, I'm trying. Oh, yes.
मी जरा डार्क आहे म्हणून दिसत नसेल.
No. It was on the other page.
Right.
Hemant, what you can do, you can put it on speaker view, so then you will see the person who is talking.
Oh, अच्छा. नाही, आता मला दिसतंय मला.
Okay.
Yeah.
हेमंत, आता 6 वर्ष झाली माझ्या सर्जरीला. मी 1.5 वर्ष अंगावर काढलं. मला असं थिंक होतं की मला खूप पेशन्स आहे. बट माझ्या डॉक्टरनी तुम्ही परस्यू केलं आणि मी केलं. मला ऑपरेशन थिएटर जास्त तर मला कधीतरी वाटत होतं की आपण यातनं परत बाहेर पडूया. पण व्हॉट हॅपन वॉज व्हेरी गुड. माझा पाय अत्यंत चांगला आहे. मी सायकल, हाईक, नंबर ऑफ थिंग्स आय हॅव डन. आणि आय रिअली अप्रिशिएट युअर स्किल. आणि मुख्य म्हणजे काय की मी कोणालाही सांगेन की अंगावर काढू नका. हे ऑपरेशन हे अत्यंत चांगलं आहे. आणि मी 3 आठवड्यात तयार झालो होतो. आय वॉज राईट ऑन द रोड विदिन 3 weeks. सो
माझ्यापेक्षा पुढे पळतात.
yeah, so I'm really happy and thank you.
Thank you, Ajit. That's very.
एक मिनिट. तुम्ही हे ऑपरेशन करताना तुम्ही सगळे ऑपरेशनला म्हणतात की त्याच्यात डेंजर आहे अमुक ते, पण ऍक्च्युअल ऑपरेशन करताना काही असे इन्सिडेंट झालाय की ज्याच्यात तुम्हालाही पॅनिक व्हायला होतं?
झालाय
सांगा एखादा.
नाही, मला नाही झालाय, पण आय witnessed it during my residency, and that is not a situation where any surgeon ever wants to be. So 1999, McMaster University, Hamilton. I was assisting a surgeon with a lot of experience who had over 5,000 knees to his credit. Very skillful surgeon, and in the middle of everything was going very smooth until the surgery went well. In those days, we used to use a device called as a tourniquet. Tourniquet is basically a rubber sleeve which is used around the thigh, आणि ब्लड प्रेशरचं कफ असतं ना तसं इन्फ्लेट केलं जातं, and the purpose is to prevent bleeding during the operation. So surgery झाली की ते आम्ही डिफ्लेट करतो, आणि whatever small bleeders there are, we coagulate them and close the skin. So I remember as soon as the tourniquet was deflated, there was a sudden gush of blood on our faces. And within seconds, or within 2 to 3 minutes, that patient lost about half his blood volume. So this is a condition where it's called a vascular injury. So right behind the knee, about 5 millimeters away, we did not realize the bleeding because the tourniquet was on, but when the tourniquet was let off, this bleeding. So this patient nearly lost his leg. Luckily, we had a vascular surgeon in-house, and the patient had to be put on the front, and vascular repair was done, and his leg was saved. But that is a situation where no surgeon ever wants to be in, because the end result could be an amputation.
Thank you.
Can I ask a question?
Sure.
Okay, go ahead.
How about these medications, glucosamine, chondroitin, and all those things? Can you save cartilage by using those?
Good question. बरेच लोक वापरतात, but there is no data to show that it has any effects on the cartilage. So it is like taking supplements. म्हणजे आपण when you go to a naturopathy store, some are good, some are, all these kind of supplements. People take them, but I tell the patient that if you're feeling good about taking them, and if your knee feels better, you could continue to take them. But in my opinion, there is no evidence to show that it helps, so it's really a waste of money.
I do take them, and I find that.
But if you're taking them, and if it's helping you, there's no harm. As long as there's no harm, you can continue to take them. The question is, have you stopped taking them and found out whether you feel the same or not?
I don't know whether it's psychological or whether it's real. But when I do stop it, I feel like I have knee pain or something.
Okay, then continue to take it. You're not doing any harm. But is there any data to show that it really helps? There is no data to show that.
So it depends on the individual, or it's just
it's just
really psychological.
I'm not saying that.
Okay. Can I ask you one question, Hemant?
Yes, sure.
2 questions actually. One question is, do you suggest surgery only when you cannot hack it, or you suggest surgery slightly earlier? Means if it starts interfering with your day-to-day life, that is when you say that, okay, it is time that you should go to surgery, or you let it be decided by the patient that I can't hack it, so now I should have surgery. Does that run the risk of delaying the surgery a little bit?
So there is a balance that needs to be maintained. So you have to remember that this operation, although it's a very successful operation with an excellent long-term result, success of the surgery really depends a lot. Really depends a lot on personal motivation from the patient, because the surgery technically, if it will be done well, the nursing care will be appropriate, anesthesia will be fine, but I found that patients who are not really motivated themselves, the outcomes are not ideal. And the reason I'm saying that is because somebody like Ajit here, he was 100% motivated. So it's a pleasure to have a patient like that. And because of that, when the surgeon has to be 100%, patient has to be 100%, and the patient's biology has to be healthy and good. When all these factors work together in unison, then the outcomes are excellent. So the reason I said this is because, so if you get a patient who has early arthritis, I'm not going to tell the patient to consider surgery. I will tell them, try the simpler things first and come back to me when things get bad. So when things get bad, or when you're reaching a stage of maybe mild to moderate arthritis, I have a very long discussion with the patient, and I try to go into the details of the symptoms to find out. Within 2 minutes, you come to know, Ashoka, whether this patient is managing well or is not managing well. Are you coping? I mean, I know you've got pain, but are you taking any medication every day? Do you take Tylenol every day? Do you take naproxen or Celebrex or Voltaren every day? If he says, nay, once in a week, then I'm fine. I'm doing exercises. I go for my walk, but it's still hurting. So I get the idea of whether it's manageable or not. As long as it is manageable, then I encourage the patient to continue to do what he's doing until a point comes where I tell the patient that if you reach a stage where you have to take anti-inflammatory or analgesic every day, then that's a stage where it's a red flag to me, because if this patient takes this medication for the next 3 to 6 months, I'm worried with what is going to happen to his renal function and kidneys. So then I tell the patient, see, all these years, you've been coming to me for 3-4 years now. You've been managing. I never said surgery to you. But now what happens when you don't take that medicine? What happens when you don't take 6 Tylenols and when you don't take Voltaren? He said, then I cannot function, doctor. Then I'm crippled. Then I'm struggling. I said, so there's your answer. Your choice is either you continue to take these medications as you're doing and soldier on at the cost of your kidney health, or have surgery.
Thank you. I wanted other people to hear this. That's the reason I asked that question.
Mm-hmm.
And second question was on Simvist. You remember I took Simvist from you.
Yes.
For both knees.
Mm-hmm.
Although you said that it will have effect for just few weeks to few months,
Mm-hmm.
dramatically, as you recall, after the one injection, I have never been bothered to the point that I required a second injection. I know someone else who takes once every 2 months or 3 months, or once. There are two kinds. One is longer acting and one is shorter acting. So he or she goes for either one of that type. But I never required it. After the one injection, I had a dramatic recovery. Although I cannot say whether it was a Simvist or I also added quadriceps drill and everything else, weight reduction and everything else which you talked about. Because such a long effect of Simvist is very unlikely, but I did have that effect.
Right. So Synvisc typically is expected to, about 60% of patients will get relief for about 6 months to a year. But having said that, I've had patients who have come to me 2-3 years after, but only because they have done other things like weight reduction, quads exercises, using a stationary bike or swimming or yoga or something else that have been more useful to them than Synvisc.
Yeah, exactly. That's what probably was the
Yeah,
cause for me.
right, exactly.
Okay.
Right. Smita had a question.
Yeah, I don't have a question. I just want to show my gratefulness. I'm your patient. मी
नमस्कार, मला आठवतं. हो.
हा, कारण माझ्या ह्याच्यात कॉम्प्लिकेशन निर्माण झाली होती आणि तुम्ही मला इंडियात जायला अलाउ केलं होतं. या इथले जे स्पेशल शूज वगैरे न घेता इंडियातून तुम्ही करून घ्या असा ऍडवाइस दिला होता आणि तो मला खूप कामाला आला. आणि सरप्राइझिंगली मला वाटतं मी नंतर जे फॉलोअपला आले होते तेव्हा सांगितलं होतं की खाली मुलं खेळत होती, त्यांचा फुटबॉलचा मोठा बॉल एकदम माझ्या मांडीत येऊन लागला होता आणि यू हॅड कट डाऊन द फिमर ऑल्सो, सम पार्ट ऑफ फिमर. आणि मी प्रचंड घाबरले होते कारण मी घरात एकटीच असायचे. हा, पण मी लगेच एक्सरे काढायला गेले आणि त्यांनी सांगितलं ऑपरेशन खूप छान झालंय आणि तुम्हाला काहीही धक्का नाही लागलेला. आणि गंमत म्हणजे त्यांनी म्हटलं की तसं तुम्ही थोडं जाडजूड असल्यामुळे तिथपर्यंत ते बॉलचा जर्क पोचला नसावा. म्हणजे कधी कधी झाड असण्याचं पण मला वाटतं काहीतरी फायदा असतो. पण ती माझी स्टेरॉइडची स्टबन फॅट काही जात नाही, पण तरी सुद्धा म्हणजे इट्स ओके, आय एम क्वाइट ऍक्टिव्ह.
Yeah, that's good. No, I remember you. Thank you for your comment.
थँक्यू.
Okay.
हॅलो, नमस्कार.
Hello. Yes.
मी पुष्पा मुळगुण तुमची पेशंट होते 5 वर्षापूर्वी. मला फक्त एक साधा प्रश्न आहे की आतापर्यंत माझ्या पुष्कळ मैत्रिणींनी इंडियात पण सर्जरी केलेली आहे आणि इथे पण झालेल्या आहेत खूप मैत्रिणींच्या. तर इंडियातल्या पेशंट्स खूप कमी तक्रार करतात की त्यांना पेन आहे आणि इकडच्या मैत्रिणी जास्त तक्रार करतात की त्यांना सर्जरीचं पेन खूप आहे, रिकव्हरी खूप आहे, रिकव्हरी टाइम खूप आहे. तर असं का, म्हणजे इज देअर अ डिफरंट टेक्निक इंडिया?
No, the technique is the same. I don't know the answer to your question. So I don't know why. I mean, it may be anecdotal, a few people here and there, but the technique is the same.
Technique same as well. Thank you. Yeah. I'm doing okay right now.
Thanks. That's good. Yeah.
Okay. Anybody else now?
Sharad Kaka is there. I can see him.
Yeah. I have one question about gout. Does it come under arthritis, or is it a permanent kind of a disease, or it can be cured? Gout.
I'm not a specialist on gout. Gout is a medical condition, and it is treated by either family doctors or by rheumatologists.
Okay.
So usually gout साठी आम्हाला surgeries usually नाही करत, and they're not necessary also.
मी ललिता यादव. नमस्कार.
नमस्कार.
मी तुमची पेशंट आहे. म्हणजे 3 वर्षापूर्वी माझं ऑपरेशन झालं आणि माझं लाईफ एकदम चेंज झालंय. मी 10 वर्षांनी यंग वाटते आता मला. मी संध्याकाळी रोज चालायला जाते आणि माझं लाईफ एकदम चेंज झालंय. म्हणजे आय गॉट अ न्यू लाईफ फ्रॉम यू.
थँक्यू.
Thank you. That's I want to tell you.
Thank you. It's very satisfying for me to get this response, and which is the reason that makes my profession and gives me satisfaction to continue to do what we do.
तुला खूप टेस्टमेंट्स मिळालेत हेमंत.
No, I know. Ashok Kaka, I was a little worried. What if I have some disasters out here when they come out? But
May I ask one simple question?
Sure.
Oh, sure.
I never had knee surgery. I live on a 5th floor and I tried to go up and down the stairs at least once.
Mm-hmm.
But I cannot go without holding on to the railings. Do I still get the same benefit?
You still get the same benefit, but what you can do is you can focus on strengthening your quads seriously. Tani खूप फायदा होईल तुम्हाला, because the difficulty that people have on stairs is because quadriceps are these muscles here,
Right.
right? So
Yes.
these muscles. So this exercise is very important with weights and all that. So my mother is 90. My mother is 91. She lives in Pune all by herself. At this age, she goes up and down stairs without holding the railing at least 4 times a day. One level, 4 times a day, and she can still get up without support from the floor into a standing position. So just to give you an example, so if you can do that, if you can try practicing, sit on the floor and try to get up, just the process of getting up and putting strain on your knees and getting up, if you can do it, that's the indicator of how good your knee function is at that age.
Okay. एक छोटा प्रश्न विचारते. चढताना मी रेलिंग नाही पकडले तर चालतं मला.
उतरताना लागतं ना,
खाली उतरते. पण उतरताना मात्र मला सतत
that is because उतरताना जास्त फोर्स लागतो मसल्स ना म्हणून.
आणि तो जाईल असं सारखं मी पडणार.
Safer to use the railing there.
मला एक प्रश्न आहे. नमस्कार, मी प्रतिभा गोखले.
नमस्कार.
नमस्कार. माझी राईट नी लॉक होते सारखी, तर त्याच्यासाठी काय करायला हवं मला?
त्याच्यासाठी तुम्हाला we have to find out whether it is actually locking. Locking म्हणजे काय होतं?
म्हणजे मी बसलेली असताना एकदम ती अशी एका पोझिशन मध्ये राहते, मला काहीच करता येत नाही. मग मी हळूहळू उभी राहते. उभी राहते आणि मग ते असा एकदम कटकन आवाज येतो आणि मग सरळ होते.
There may be a loose piece of bone किंवा meniscal tear वगैरे असेल, तर you need to go to your family doctor and get a referral to an orthopedic surgeon. आणि you'll probably need X-rays and a MRI scan.
I see. All right. Okay. Foreign doctors. Okay. Thank you.
श्रीराम, विश्वनाथला बोलायचं आहे.
हा, विश्वनाथ.
नमस्कार.
विश्वनाथ कुठे गेला?
म्यूट करा त्यांना. विश्वनाथ अनम्यूट करा.
मी काय म्हणतो की साधारणपणे ही जी सर्जरी आहे ती त्याला हिस्ट्री काय आहे, किती वर्षापासून झालेलं आहे?
Sound quality is not good.
मायक्रोफोन बरोबर होत नाही, काम करत नाहीये. तुमचा आवाज अजिबात मी कळत नाही काय बोलताय ते.
ओके.
आणखी कोणाला काही प्रश्न आहेत का? ओके, त्याचा आपण आपला सेशन संपूया. मीना दाखवा.
Yeah. Dr. Hemant Shirali, I would like to say a lot of things, but I'm trying to keep it very concise. Senior citizen, I know very well that we all need a knee care sometimes or the other, and dedicated orthopedic surgeons like you impact our lives in a very positive way. Thank you so much for the positive impact on us. After surgery videos that you showed were excellent and very encouraging. I would like to express our sincere appreciation for your valuable presentation, which was very comprehensive, giving risk factors, symptoms, stage of arthritis, different necessary medications, and various challenges one has to encounter, including prevention. I specifically would like to mention that the pace of your presentation was so appropriate that help us to be attentive and help us to understand what the disease is all about. Because this we don't get it by sitting in doctor's office. So it was tremendous addition to our knowledge, not only for us, but in case somebody else that we know is going through that, and maybe we can add our knowledge and give some benefits. We hope so. So thank you so much for the encouragement and letting us stand on our feet and keep moving. Thank you so much.
Thank you, Minata. Thank you very much. Pleasure being here.
माझा आवाज येतोय का?
तर आपण आता आपला कार्यक्रम थांबूया. आज आम्ही सगळेजण थोडेसे आम्ही
Yes.
Thank you again. Thank you.
Thank you very much.
Bye.
Okay.
I'm going from my walk now.
Thank you very much, Hemant. Yeah.
Bye, everybody.
Okay, bye, everybody.
Bye.
Bye. Yeah, that was wonderful.
Thank you. Thank you very much.
खूप आवडलं.
That was excellent.
आता ऑपरेशन होऊन सुद्धा कळलं नव्हतं नक्की काय झालं होतं ते, पण या सगळ्या माहितीमुळे कळलं. थँक्यू.